But to begin, again, I'm Amanda Tavelda, and today we are doing our evidence-based palliative symptom assessment management on depression. Now I'd like to go on to our land acknowledgement. We would like to acknowledge that the land in which we are gathered on today is a traditional territory of the Anishinaabe Nation, specifically the Chippewa Tri-Council Compromise of the Chippewa, Beausoleil, Rama, and Georgina Island First Nations, and more recently, the Mississaugas of the Credit River First Nation. Ontario is covered by 46 treaties and other agreements and is home to many Indigenous nations from across Turtle Island, including the Inuit and Métis. These treaties and other agreements, including the One Dish with One Spoon Wampum Belt Covenant, are agreements to peaceably share and care for the land and its resources. Other Indigenous nations, Europeans, and newcomers were invited into this covenant in the spirit of respect, peace, and friendship. Most of us have come here as settlers, immigrants, or newcomers. In this generation or generations past, we are all treaty people. Every day, we are mindful of broken covenants and we strive to make this right. We commit to collaborating based on the foundational assumption that Indigenous peoples have the power, strength, and competency to develop culturally specific strategies for their communities. We are dedicated to honoring Indigenous self-determination, history, and culture, and are committed to moving forward in the spirit of reconciliation and respect with all First Nations, Métis, and Inuit people. And now, as most of you know, this is the Palliative Care ECHO Project. The Palliative Care ECHO Project is a 5-year national initiative to cultivate communities of practice and establish continuous professional development amongst healthcare professionals across Canada who care for patients with life-limiting illness. And as I mentioned earlier, we would like to thank Health Canada for their ongoing support for this initiative. Without their financial contributions, we wouldn't be able to do what we're doing today. So thank you. And now I'd like to introduce our speakers. Today, we will be joined by Nancy Good-Kennedy and Sherry Hubbard, both of which are hospice palliative care nurse consultants with the North Simcoe Muskoka Hospice Palliative Care Network. Nancy, Sherry, the floor is all yours.
Thank you, Amanda, for this great introduction. I'm Sherry Hubbard. I'm a registered nurse working with the North Simcoe Muskoka Hospice Palliative Care Network. And it's my pleasure to speak to you today about depression in end-of-life situations and people that are facing life-threatening disease. I'll ask you if you could please remember to complete the satisfaction survey. It's really important for us to grow and evolve and better the presentations and ourselves as we present this information. And as you know, depression is a huge topic. And this is just the tip of the iceberg. There's so much information, education, and new information coming out every day. So I think, by the ripple effect, we'll be able to create some change and some questions and some change of practice, which is wonderful, right? Today, our learning objectives, by the end of the session, we're going to discuss the etiology of depression, develop an understanding of normal versus pathophysiology of this challenging disease, and review the clinical assessment tools that are used with depressed patients suffering from depression on top of their already life-threatening disease, and identify the non-pharmacological and pharmacological treatments that are available. And if you were with us with our anxiety topic last month, as you know, Cancer Care Ontario puts these algorithms out to help each of us identify the patients that meet criteria for these symptoms and hopefully with best practice, help support them and families. And understanding that not just cancer patients fit into these categories and would benefit from these strategies, this information, and also with these tools, these validated, peer-reviewed tools that we're going to share with you. If we're going too fast, just let us know. If you want us to repeat something, go ahead and speak up. So welcome to the review of depression at end of life, a palliative approach to assessment and management of depression. If you followed our previous ECHO presentation on anxiety, you will understand that depression is an illness, not a choice. That depression is a complex and of course is often left unassessed, brushed aside, leaving patients that are experiencing depression along with their life-limiting disease at risk. Sadness is a temporary state of mind triggered by difficult or challenging experience or events in human life. But sadness is a result of something we've experienced. We've all had sadness in our lives. Depression, however, is a mental illness that affects our thinking, our emotions, our perceptions, and behaviors. Its etiology, as you will see, is based on a series of symptoms, pathology in the brain that we have theories about. There's really very limited diagnostic tools that can tell us about depression, such as CTs or ECGs or lab work that will help definitively diagnose depression. Thus, as a healthcare providers, we must be diligent in recognizing who is at risk for depression, how to assess the risk and depth of the disease itself, and where can these people get help. Pharmacological treatments along with non-pharmacological treatments are available. And understanding that our society, although we've come a long way in understanding depression, it is still fraught with many bias and lack of understanding surrounding depression and its psychiatric illness. And it's up to us to normalize that this is a disease and help people understand that no fault of their own, they have a disease like this, much like any other inflammatory diseases that we see, like coronary artery disease, type 2 diabetes, that they require treatment. And depression is not a homogeneous disorder, a uniform in nature, homogeneous, sorry, not homogeneous like milk. It is a complex phenomena which has many subtypes, and probably more than one etiology. It includes a predisposition to episodic and often progressive mood disturbances, and differentiates in symptomology ranging from mild to severe symptoms. It may be with or without psychotic features and interacts with other psychiatric and somatic disorders. And when we put that on top of already complex other health conditions, it's very difficult to tease out which symptoms belong to which disease. Historically, there's been a lengthy discussion on the basis and classification of depression. And two different concepts were created and formulated of depression as a disease. This was from Emil Kaplan's formulation of depression and Sigmund Freud's view of depression as a manifestation of internalized anger and loss, were the two opposite points of view at the beginning of the 20th century. It was the merit of Sir Martin Roth and the Newcastle Group that contributed to the understanding of depression. They classified depression, clinical depression, manifestations of depression from mild to severe psychotic in a categorical manner, separating them into two distinct groups of endogenous and reactive subtypes of depression. This concept was used for decades in biological psychiatric research in order to identify etiology, different subtypes of the disorder. The recent editions of the DSM-5, remember that's the golden tool for depression and mental health disease, and the International Statistical Classification of Diseases 10th revision follow the results from collaborative projects across the United States, UK, and distinguish unipolar depression and differently from bipolar manic depressive disorders. And when we think about depression, it is potentially a life-threatening disorder that affects hundreds of millions of people all over the world. It can occur at any age, from childhood to late life, and is a tremendous cost to our society, as this disorder causes severe distress and disruption of life. And if left untreated, can be fatal. And I really want to emphasize that by talking about this with patients and families is not easy. It never is an easy conversation to begin. It never is something that you can enter lightly. However, remembering that we will not cause the person harm or cause them to be depressed or be suicidal by talking about this subject. Just the opposite. They may be willing to hide it and be allowing it to go untreated and become pathological unless we use our tools to intervene. I'm going to pass the very important part of physiology and pathology of depression to Nancy.
Thank you, Sherry. When we talk about physiology and pathophysiology, especially in depression, we really want to know, to begin with, how our brains work normally versus the functional changes that come along with a particular syndrome or a disease. So normal physiology of a patient's mood, emotion, and behavior focuses majorly on neurotransmitters in the brain. There are over 46 neurotransmitters, and many have more than one function. They use electrical signals to stimulate messages along the neurons, where it affects ion channels and eventually performs a specific mechanism at a site of action. So serotonin is one of those neurotransmitters that we do hear a lot about, and it does play key roles in our bodily functions for mood, sleep, digestion, nausea, actually wound healing and bone health, as well as blood clotting. And it also plays a role in our sexual health. Norepinephrine, the locus cereolis, has a group of norepinephrine containing cells that are implicated in global psychological processes like attention, vigilance, and orientation to stimuli. Dopamine plays in our reward system. And when we talk about our mechanism of depression and how that happens, I really like to give some credit to Dolores Garcia, who is she has a PhD in molecular biology, and she has used her skills to help us understand a molecular mechanism that really does drive neurodegeneration, or neurogeneration. So we do see that there are different types of transmitters. The normal process, where we actually have a high concentration, and when within the synaptic cleft. With depression, you'll note that that concentration has lowered itself. And we as clinicians want to be able to identify, know when treatment is appropriate, and then we can look at the success at the end when we have treatment and we notice that those concentrations are on their way up again. So that does cover the mechanism of depression.
Did I go ahead too fast, Nancy? Did you want me to go back?
No, that's great. Thank you.
Okay.
Thank you. So when we talk about mood disorders, they're still being studied, and due to the unclear nature of how they occur and to the difficult availability of human brain tissue for neurochemical measurement, that really does happen post-mortem. So each of these dysfunctions below, they focus on what are thought.
I think it's okay. I think someone just muted themselves.
Okay. They're what are thought to be the causes of major depressive disorders. So for a long time, and especially in the field of psychiatry, little was known about the biological substrates of the disorders, and the work of Julius Axelrod and several other Nobel Prize winners has significantly contributed to the understanding of brain function. So the genetic predisposition and the environmental influences, there's a genetic predisposition in major depression that runs in families. However, due to the large variance in symptoms, developmental and environmental factors also must be evaluated in the contributing factors for that major depression. And the combination of life's stressors and potentially a dysfunction in the serotonin system as well. The serotonin transporter serves in the reuptake of serotonin, and it may moderate the response to stress. Oh, sorry, Sherry, could we just back up one slide, please? And
There we go. Sorry about that.
No, that's great. No, that's great. Thank you. So when we talk about neurochemical dysregulation, we're talking about the monoamine hypothesis of depression. And it states that there are antidepressant drugs that increase neurotransmitters in the body. And in this hypothesis, there is a deficit in the concentration of the brain norepinephrine, dopamine, and or serotonin that results in depression. And antidepressant therapies focus on increasing the neurotransmitter levels within those synapses that we saw earlier in the mechanism moderation. So when we talk about neuroendocrine dysregulation, there are two theories in that pathophysiology of depression, and they involve the dysregulation of the neuroendocrine system itself. So the first one focuses on stress and the hypothalamic pituitary adrenal system. And the second neuroendocrine dysregulation is in the hypothalamic pituitary thyroid system. And just as a sidebar and of interest, when we talk about neuroendocrine dysregulation, it makes me think about pancreatic cancer and our palliative population that suffer with pancreatic cancer often have a high rate of depression. And I did look at a couple studies, and I also have listened to Seth Resnick, and he spoke about how often with pancreatic cancer, one of the very first symptoms may be depression. And he felt and gave some credit to the neuroendocrine dysregulation. So I just wanted to mention that because I thought that was really quite interesting because we do hear a lot about it. So the third, the neuroanatomical and function abnormalities, depressed individuals post-mortem brains have shown widespread disease in serotonin 5 and the HT1 receptor subtype binding in the frontal, temporal, and the limbic cortex. And it may suggest an indirect role in the modulation of that serotonin function itself. So norepinephrine receptor alterations are found in the frontal cortex of some suicidal victims that have suffered from depression. And depressed individuals have also been found to have abnormalities in cerebral blood flow and as well as glucose metabolism. Thanks, Sherry. Now we can go to this. So here we are again. I always say when we're doing these echo presentations, we have all kinds of learners. So for those visual learners, this is a synaptic cleft and the steps of the chemical transmission that are taking place. So those precursors are transported from the blood into the brain, and they're converted into transmitters with the use of an enzymatic process. So the enzymes are everywhere, right? And they really thread through that cord of the brain relating to the stomach, the digestive system. So transmitters are released into the cleft where they either react with the autoreceptors to regulate the synthesis and then release, or with the postsynaptic receptor to induce the events of downstream signal. Thank you, Sherry.
So that's a lot of heavy pathophysiology early in the afternoon for all of us. Thank you, Nancy, so much for making it visually understandable and get us thinking about what is actually happening in the brain of someone who has depression, right? And with an understanding of what is considered normal and what is considered abnormal, It is only through diligent assessment using peer-reviewed screening tools that our medical community is capable of making formal diagnosis. And with a diagnosis, we then can focus our attention on treating patients that suffer from depression. And it is imperative that we dig very deep and we ask and use these validated tools. And we will go into some of these tools and treatments. Understanding that just by simply asking, are you depressed, is a great way to start the conversation, but it isn't all of what we're going to do. We need to really be able to identify the somatic symptoms that come along with depression, but also come along with other disease processes that might be going on. For instance, cancer, things like poor appetite and weight loss and fatigue, anorexia, severe fatigue, all of those symptoms that may cross over. But really, when you think about looking at these tools, we know that some of these physical and psychological indicators are how the person looks, social withdrawal, the way they're feeling about themselves, self-pity, pessimism, lack of happiness, worthlessness, guilt, and a wish to die, a pervasive desire to end it all. Maybe not with any type of clear intent, but are thinking about this frequently. And we know from practice in the past that if we use validated tools like ESAS and the PHQ-9, these are validated tools, and the PHQ-9, if you aren't familiar, is the Patient Health Questionnaire to assess for depression in adults facing a life-limiting disease. And thinking about when these symptoms occur and the response to treatment modalities, watching for key critical times in disease and treatment process. For instance, the new diagnosis is a critical time where depression may rear its head. New diagnosis, critical times in transition, post-treatment survivorship, and as they near end of life or other lifetime stressors may bring along these symptoms of depression. And at present, the essence of major depressive disorder is a clinical course that is characterized by one or more depressive episodes without any history of mania, mixed or hypomanic episodes. So we're just talking strictly depression. And the pathological state involves a triad of symptoms with low or depressed mood, low energy or fatigue, other symptoms such as sleep and psychomotor disturbances, feelings of guilt, low self-esteem, suicidal tendencies. They may have some autonomic and intestinal disturbances. They may be present as well. And when we start to look at the predisposition, have they had other times in their lives where they've been depressed? And has anyone in their family had depression in the past? And all of these symptomologies are different, and we need to categorize them from mild to severe. And so we're going to show you the Cancer Care Ontario algorithm. And I know this isn't a fabulous screenshot of this, but we're going to break it down for you so that you can see it step by step and more clearly. Now, remembering again that we don't just use this algorithm for cancer patients, but for other patients that are experiencing a life-threatening disease as well. So if we move on to the screening tool right now, we start off with caregivers and the patient and the healthcare team trying to sort out where the patient is in this ESAS screening tool, and remembering that it's important that the patient be the one that is answering the questions. As a family member or caregiver, you may perceive different things that you're seeing in a different manner than what the patient actually is feeling. And often, of course, we can't differentiate between our own feelings as caregivers when we see a loved one suffering. So it's, if possible, it's best that the patient themselves is able to do the tools themselves. And we need to ask. We just need to ask the questions. We need to know if they've been feeling down or depressed, and is it over greater than 2 weeks? Because then we're starting to differentiate between sadness and reaction to very serious disease and a very challenging coping time in their lives. Do you feel down or depressed most of the time these days? Have you lost interest or pleasure in all or almost all of your activities? Are you feeling down or depressed, and does it impair your daily living? If the answer is yes to all of the above or any of the above, we're going to categorize them into that moderate to severe area. And we know that we need to go further and dig deeper. So definitely challenging to single out the depressive symptoms that may be related to physical or medical symptoms that are part of the disease that the patient has. So making sure that we do a really good head-to-toe assessment, assess all the medications, and really review what those symptoms, the patient thinks those symptoms are related to. What have they tried already? What's worked? What hasn't worked? All of the things that we do every day while we're assessing people. And trying to find, ruling out those medical reasons. Is there any intervention that we can do to get rid of or alleviate some of those symptoms? And then we need to move on and see which are truly related to the patient's mental health. And if you need help and support, we need to be able to reach out to the professionals that look after depression every day. We can't expect ourselves to be experts in every mode of healthcare. So if we're looking at the depression scales, an ESAS scoring of 1 to 3 is mild depression. So providing patients with a guide how to manage your depression, supportive care education, and providing information about community peer-led support groups, counseling, and mindful wellness. And remembering that, again, there's bias and there's judgment surrounding this still in our society. So making sure that patients and families understand that this is a treatment that we would utilize for any kind of medical disorder. And people are often reluctant to go forward. So it's really, really important that we help them understand it's not because they're weak or not prepared to cope or have poor coping mechanisms. These are true diseases. If we go to the moderate depression, we're looking at an ESAS score of between 4 and 6. And if you're, again, just concerned about different things, ask the questions and know that probably at this point, when we're getting to the moderate phase of this, further assessment is definitely required to keep this patient safe. So looking at their environment, does the person live alone? Are they able to identify a certain support system? So I always like to ask people, who can you call other than your spouse? Is there someone you could call at 3 o'clock in the morning if you needed to? And would they be able to support you? Has there been a previous history of mental health illness in your family or with the person? Is there alcohol or substance misuse? And we know that these people with alcohol and substance misuse are at high risk for depression. Is there a presence of comorbid anxiety? And if you recall from the anxiety presentation, these two often interlap, and often anxiety is one of the symptomologies of moderate depression. And what current life stresses that are unrelated to the disease process that they're going through right now would precipitate a depressive symptomology. Now, when we get to the severe depression, ESAS score of 7 to 10, we know that we need help. We need to refer to psychosocial support And we need to assess the risk of suicide and following emergent protocol. Asking people specifically, have they thought about harming themselves? And I would start this conversation with, when people are feeling down, they can have thoughts of ending their lives. Are you having thoughts like this? Is there a chance that you would do something to end your life? And knowing all of those symptoms that go along as people prepare to end their life by giving away precious commodities that they have of their own, actually really preparing for end of life. So if that's the case, we know that this person likely needs more support than we can offer them. So when we look at evidence-based therapeutic interventions for patients and their loved ones that will provide them information, support, and help them better understand the disease and the ability to cope. So for all of our cases, psychoeducation is really important. Active monitoring of the disease so that we can actually intervene when we notice somebody getting worse and not, having some good outcomes from the interventions, and looking for further assessment and interventions that may need to be offered. So with the mild to moderate, low intensity psychosocial intervention, structured group physical activities and programs, group-based peer support and self-help programs, guided self-help programs based on CBT, and behavioral activation or problem-solving techniques, and some medication may be needed at this point in time. And again, we're going to reach out to some well-educated people that are very apt at diagnosing and prescribing antidepressants. So when we look at the mild to moderate major depression with inadequate response to individuals with initial presentation of severe depression, so there is a threshold that we need to look for, and we're going to look at that algorithm, and it talks about the first line antidepressant symptoms or antidepressants, and using high intensity psychosocial interventions. Perhaps there's some behavioral couples therapy that will help that partner understand what that patient's going through and how they can help and not actually cause harm. Individual or group psychotherapy and collaborative care with the oncology team, the primary care nurse, social work, and psychologist. And pharmacological treatment supervised by a consulting psychiatrist if needed, to make sure that we're using the right drug at the right dose for the right reasons, as we do with every prescription and medication and treatment that we use. With complex depression, with suicidal tendencies, self-neglect, or psychosis, we can expect that these patients will need to have a psychiatric admission where they can be kept safe and monitored with combined treatment modalities. With the psychological treatment, I'm going to pass this back on to Nancy here. And there's so much research going on with this, Nancy. I think we're on the precipice of being actually able to treat depression in a manner that is very effective.
Thank you again, Sherry, very much for that. So I just, first of all, before I get into how we determine when, how, why, and where, I did want to mention that just in the research that I have been doing over the last little bit in relationship to depression in our palliative population, I've noted a number of times clinicians coming forward with the thought that perhaps treatment for depression, at what point should they treat the depression pharmacologically, and is there any concern that perhaps it could interrupt the process of the patient dealing with their end of life factors to begin with? So is it going to impede their ability to work their way through the emotions that would naturally come along with end of life symptoms? So I think we really need to take a look at the severity, and as Sherry's already mentioned, the duration, and the chance of a spontaneous recovery, is that going to happen in 2 to 4 weeks' time? Because we know that some of the medications do take up to 3 to 4 weeks to actually take effect. However, certainly not all patients that come to the end of life are depressed. So, and even if they are, they can be helped. So as we move through the choices of medications and talk about the effects of different drugs, we'll want to consider what those side effects may be. So. We can just turn over to them. That's perfect. That's great. So when we're looking at the tricyclics and being replaced by the SSRIs, we want to think about atypical antidepressants and the use of those drugs versus stimulants. So we talk about amitriptyline and we talk about adjunct drugs along with the mood stabilizers. They come in. When we're talking about someone that has neuropathic pain, I know that
Nortriptyline.
Thank you, is of the choice. So we want to start with our start low and go slow always, and we'll increase every few days to weekly. And we'll also note that venlafaxine or Effexor, it is not a good drug for end of life due to its short half-life, and it increases the risk for withdrawal syndrome when a patient is no longer able to take the medicine. And also, it's important for us to note that with primary care physicians, perhaps that aren't focusing in palliative care to begin with, sometimes we have a hard time actually having them fulfill the scripts that we would like, because some of the medications, let's just say, have been kind of termed dirty over the years, and that's because of the side effects that they're fearful their patients may have. And that can be because they do. A lot of these drugs do hit on many of the receptors. So Celexa seems to be one of the drugs that I do see ordered most often for depression, and that's because it doesn't hit on as many of the receptors. So they're now terming that somewhat a clean drug. So isn't it great that we've gone from classifying something as a dirty drug over to actual clean drugs? Thank you, Sherry. I think we can carry.
And Nancy, would it be fair to say that we need to remember that it depends on where that patient is in the trajectory of their disease process and what their goals of care are before starting any of these treatments? We really need to look at the amount of time that person has left, and are they going to get the benefits of these medications, as they do take time to develop a level where they're effective. So I'm not sure that I'm not sure that I said that in the other slide, but I just wanted to make sure that we brought that up again to remind it's always about goals of care and where that patient is in the trajectory of their disease, just for any treatment that we're considering.
Absolutely. Absolutely. And also of noteworthy is the trazodone, particularly. I did see some research that trazodone does tend to be habit forming. So you may see people shying back from trazodone a wee bit, and the doses too that are given here. So the 100 to 300 milligrams a day, and it is stated that they may require higher doses than that. But there's actually some studies now showing that lower doses may use trazodone in a lower dose to actually help with insomnia, that for people that are maybe freshly diagnosed with a cancer and they have those 5 fears, right? So if they're not sleeping at night, trazodone has been and is getting more of a, let's say, front seat at a very low dose, because they don't want to be sedated, but they do want to sleep. So there's so many things, and that does go right back to our goals of care. There are so many things to take into consideration when we are prescribing or asking for medication to be prescribed for our patients. I wanted to also just mention, when I see the Wellbutrin, there is a concern when prescribing SSRIs, the side effects. So one of those side effects that does come up is it does cause some effects with libido. And it was the same gentleman that I listened to, Redrick, that also suggested perhaps adding Wellbutrin, a low dose of Wellbutrin with the SSRI may counteract. And I think that that will be really helpful moving into the future for that population, especially the young population, right? That is still a concern for.
And also just remembering that a lot of these drugs do have some pretty significant side effects, such as constipation. So we've already got a portion of population that are on opioid therapy and may already be struggling with constipation. So just having that in the back of your mind, and that be one of your thoughts about drug interaction. Prolonged QT syndrome for those patients that might be already on drugs that are prolonging their QT, which puts them at risk for lethal arrhythmia. Again, with those goals of care, if you know someone is nearing the end of their lives and this therapy is in congruent with the symptoms that they're looking at, we may just choose to just monitor that QT with an ECG. So just keeping those types of things in the back of your mind as your patient goes forward with this. And there's another list of the tricyclic antidepressants. There's so many of them. And I think, Nancy, you would definitely agree that it sometimes takes a specialist to tweak these drugs and the experience of the person that's ordering them and monitoring and titrating.
Mm-hmm. Well, and I absolutely, Sherry, and I also certainly, not every person that is entering, as I said earlier, is entering the end of life are depressed.
Correct.
That is just, that's not the case. And if they are, they can be helped, earlier stated, right? And when we think about what the symptoms of that depressed person are, so how the severity, if they are severely depressed, we are going to medicate totally different, and we may actually end up layering medications, right? And perhaps at some point, that state of actual sedation is a welcomed measure. So it all depends, again, on the goals of care. So thanks, Sherry. Thank you for that.
So we're going to move on to the non-pharmacological management of depression at end of life. And Nancy is going to continue because this is definitely one of her very, very excellent specialties.
So when we think about non-pharmacological management, before trying to figure out what kind of treatment we opt for, we need to make sure that we're covering basic self-care. So including regular exercise, adequate sleep, proper nutrition. All three of these can have an influence on depression. Pattern interrupts are a way to change a person's state or strategy. We all have behavior patterns that are habits, subsequences, or mental pathways. And usually habits are useful, but when we get on autopilot, and that means that our brains have become so super efficient at doing something that we can turn out our conscious minds. We get dressed, we drive, we walk, we clean our teeth in ways that don't really need much attention at all. And then these patterns can be our own downfall too, because our unconscious then excels at running patterns or programs automatically. And this frees our conscious resources to ponder other matters while we perform certain activities unconsciously. That's all well, but sometimes it can be problematic, and especially when we're trying to change your own or someone else's habitual patterns of thought, emotion, or behavior. We want to change, but your unconscious keeps doing the same old thing over and over again. So it's useful to interrupt that and find a resourceful state. So when we talk about cognitive behavior therapy, we're actually talking about changing old ways or changing negative behaviors through new patterns. Also acupuncture, which I am a really big fan of, traditional Chinese medicine technique. And it's actually, when people have a fear of needles, I always tell them that that needle is really tiny. It's almost like a piece of thread. And it's inserted into the skin, and it just literally sits below the dermis. It's not as though it's going deep, unless of course you're treating something like sciatic pain. But the idea is to help balance the qi, or the good energy, and keep energy flowing throughout your system. Also, naturopathic medicine and lots of supplements. Be really, really careful and really diligent when you're doing your assessments. Make sure you ask your patients, what supplements are you taking, and have you passed that through your pharmacy? Because there are herbs and supplements, vitamins that can interact with medications, and that definitely needs to be passed through pharmacy to begin with. Also, there's the transcranial magnetic stimulation, and it stimulates nerve cells that influence mood and also can have effect on depression.
And Nancy, sorry, I was going to ask you about some of the ways that you know to change that negative spiral. Were you heading down that road?
I'm not exactly sure, Sherry. Are you particularly speaking about one of these interventions in particular, or as a whole?
I think that you had talked earlier about interrupting these negative spirals that people can get into.
Yes.
And I was just wondering if you were going to give some examples of that. Sorry. Things like kindness and comedy and those other types of motivational ways of fixing or helping fix those patterns.
Mm-hmm. Mm-hmm. So there is definitely, again, research that talks particularly about acts of kindness. And that's why we have a day that is actually dedicated to acts of kindness. It is proven science that if you give, you as the giver receive more in return psychologically than you do actually as the taker or the receiver. So that's that ongoing act of kindness. Comedy, coping mechanisms through emotional support videos, imagery galleries, there are just such an abundance. And you can find the joy in image by training your brain to bounce off a negative cycle onto a positive cycle by looking, for example, deep into a tulip in the summertime. And the reason that that happens is because you're looking for something deeper than the stem of the tulip. You're actually registering in your brain, and you're changing old negative patterns. There's again a multitude of life-changing books. There are so many self-help programs, and I really do encourage people to try and focus on movies of inspiration, self-management, uplifting music. Music has really gotten a lot of attention as well. And that will be a whole project all on its own, on how does music actually change our neurochemicals. So lots of things coming in the future. Right.
Sorry, I didn't mean to interrupt you, but I wanted to make sure that we talked about those. They're so important. So I think we're on to the next slide here, electroconvulsive therapy, and I'll leave that with you. Sorry.
No, that's okay. So it's moderately invasive, and the approach is where you actually are given a shock. And even though it seems extreme, I say that because it seems extreme to me. I do know that there are people that have been helped with this. We talked about pattern interrupts earlier, and again, you can find all kinds of resources online. I do really want to highlight this Lifeline Canada, the online resource. Please take a look at that. a lot of my research when I'm dealing with clients that I feel may be suffering from depression, and I'm looking actually for ways that I can help them non-pharmacologically, I do refer them, and I encourage you to take a look at it as well.
Thank you so much. Nancy, I think that we can all agree that we're sort of on the precipice of really beginning to understand depression, the pathophysiology behind it. You know, we're changing the attitude and the thoughts behind depression. So as our society begins to accept that this is a true disease, that people don't choose it, and they're not somehow responsible for getting it, I think we're going a long way, and the future is looking brighter. I read a very interesting article recently about utilizing ketamine infusions and psychotherapy, and using that dissociative state in which ketamine can make people, and the psychotherapy along with has been very successful for treatment of irretractable depression. Now, single depression, not with mania. So I think we need to stay tuned and stay, you know, really involved, and do a lot of reading about this, because it does affect a lot of patients over the spectrum, and non-patients, patients that aren't sick. So, and remember, using that algorithm is one tool. Cancer Care Ontario has their primary care steps to identify, and I really like using that tool, and it has the ESAS in it, and utilizing all of these different algorithms to help us assess, monitor, and treat patients. So we're going to come to a case study now, because everybody loves a good story about a patient that helps us put all the pieces together. And so this is Mr. Roy. He's a 71-year-old retired bank clerk. He is married. He has no children and no other family in town. He's a devout Christian, and up until recently has been getting a lot of comfort from his faith. He was diagnosed 2 years ago with colon cancer, and he has metastatic disease to the liver and retroperitoneal. He was admitted to hospital because his wife just simply was not being able to cope with his increasing weakness. And isn't that, you know, a case that we see so frequently, that the caregiver just becomes so overwhelmed by the responsibility, physical and emotional, of looking after their loved one. His PPS is about 40%. He has poor appetite, has lost considerable amount of weight over the last few weeks, and has been spending most of his time in bed. And he says that he just feels tired. He has lost interest in food and has refused an appetite stimulant. He's on some medications, of course, and he's on morphine 10 milligrams PO-Q4H, naproxen 250 PO-TID for his back pain, which is secondary to the retroperitoneal spread. And his pain has been fairly well managed up until now. And the lab investigations reveal no metabolic abnormality that would affect Roy's mental health state. And he has no cognitive dysfunction, although he seems slow in answering his questions. So when we think about assessing this patient and remembering about the goals of care and the risk benefit of treatment that we are contemplating, and thinking about how long that therapy will begin to take therapeutic help, and what interactions may be helpful and what might be harmful. And so let's move forward and start our study with Mr. Roy. When we are doing our head-to-toe assessment, make sure that it is robust and it's full, which means not just the physical assessment, but assessing the medications, assessing laboratory results if they're there, and really looking at the depression scale as well. So the nurse notices that Roy does not say much, and that he spends most of his time staring into space. Occasionally, he has been having episodes of crying. And on discussion with his wife and friends, the teen learns that Mr. Roy is usually a very outgoing man, He enjoys reading and crossword puzzles and woodworking. However, over the last 2 months, and that's kind of important, right? That prolonged period of time of sadness, he is not engaged in any activities that normally give him pleasure. He says to the nurse, I have been a burden to others all my life, and God is punishing me for my past sins. It would be better if it was all over now. Mrs. Roy states that her husband has been expressing inappropriate guilt for minor transgressions that occurred long ago in their relationship. And these expressions and his low sense of self-esteem surprise and distress her. Although she's not concerned to the same extent by his sadness, saying, "Isn't everyone with cancer sad?" Mr. Roy has trouble falling asleep and awakens early in the morning. He has noted a loss of libido and frequent impotence over the last 6 months prior to admission. And while he usually avoids the issue, on one occasion he said, "I'm really useless to anyone, aren't I?" His sister has suffered from depression and responded to tricyclic antidepressants. So we've got a lot of really good information here already, and I'm sure that the red flags are going up for all of you, and you're starting to, really think about what is truly going on with Mr. Roy. Is it just the physical condition of cancer, or is he depressed? And considering the family history that is liable to depressive episodes, somatic symptoms associated with depression, weight loss, and loss of appetite, severe fatigue, and loss of libido, and the change in sleeping patterns. It is, again, challenging to tease those symptoms out because of the cancer diagnosis. But these are fairly new symptoms that he's having over the last 2 months, right? And it's gone on for an extended period of time. So it's really vital for us to carefully assess the thought content in these patients. And on top of intense sadness and a sense of worthlessness and devaluation of past accomplishments, the diagnosis hinges on the presence of a depressed mood and of the associated of these ruminations. And one clue for depressed patient over a sad patient is the reaction to bad news. The depressed person is not easily distracted or cheered.
Sherry, I think someone was asking about the assessment slide, backing up to
going back to the algorithm itself. Is that what you want to do?
I think it was the first slide that starts the case study. They were looking to reread the information. Yes,
I think that's it there. Is that okay? Sorry if I moved too quickly through it.
No, that's okay. I think she'll come back and tell us if this is what she's looking for. That's
okay.
Good.
I'll give you just a few minutes to have a look at that.
Mm-hmm.
And I have no idea what time it is. I have not been keeping track of the time at all. Oh, I see it's 2 o'clock. So we'll move forward. And then thinking about, are there any iatrogenic or organic medical factors that could have contributed to his depressed mood? And when we talk about these iatrogenic issues, it's actually the healthcare team that sometimes triggers these. When we say things in a way that is not very compassionate, or perhaps we've given bad news in an environment that isn't conducive to compassionate, really good conversations. And delivering bad news needs to be been very thought processed, and really make sure that we're doing it well. We in healthcare, we're busy, often don't have a lot of time to sit down and talk to people. So there can be a lot of misinformation or misunderstanding about things that we say. And this can affect people very significantly. And how would you know that? Would you be able to ask Mr. Roy about that? But you do conclude that Mr. Roy is depressed, and then you're going to start to try and categorize where he is in his depression. And we'll go ahead here. And we did start him on an antidepressant. And as we see, he also was started on some prednisone. And he's been seeing an acupuncturist on an outpatient basis. And over the next 3 weeks, his mood began to brighten. He was sleeping better. His appetite improved. And he was smiling and had more interest in the activities on the floor in the hospital. And his faith became again a positive element in his life. And so he was able to go home, and he was able to die peacefully 3 months later at home, as were his wishes. So, doing that very robust assessment on him and taking the time to sort of tease out the symptoms that he was presenting with, and, making sure that all of the cancer symptomology was being well treated, but also that the depression was being treated. And I'll get you to just remind you carefully to finish this satisfaction survey again, so that we can grow and evolve and improve. Your suggestions and comments are well appreciated. And now we'll open the floor for any questions. Of course, there's reference slides too, so.
I'll just take a look at the chat.
That was fantastic, ladies. I thoroughly enjoyed your fulsome discussion with regards to the depression and where it's been and where we're going with it. And just to answer a quick question, yes, we will be sending out a copy of the slides to everyone following today's presentation. You will receive a copy of the slides, as well as a link to watch a recording and a copy of the algorithm that the ladies discussed here today.
I was just looking, and someone has asked about the effectiveness of neurofeedback with depression at end of life. So I have to actually tell you, Sonia, that I'm not sure, Sherry, if you came across anything with the neurofeedback when you were doing your research, but that's something, Sonia, that I actually would have to get back to you. And certainly I'm happy to do that. So stay tuned. I know the biofeedback seems to have some effect for sure. I'm just not exactly sure if we're meaning the same thing through neurofeedback as biofeedback. So I will take your name and I will certainly get back to you, Sonia. Thank you for the question. I don't see any other. Lots of people introducing, but not much in the way of questioning. So
perhaps those questions will come later, and when you go back over the information and start doing some reading, Pallium's handbook spends a lot of time really talking about assessment tools and treatment modalities and how to have the conversations. It's very, very helpful, along with using Cancer Care Ontario's algorithms and their primary care pamphlet. So, you don't have to do it alone. And if anything that I've learned over the last 35 years of my career, watching really excellent clinicians talk to patients, assess patients, you learn so much by that experience, and you begin to emulate some of those really positive things that you see. So connect yourself to those incredible mentors. Ask, can I sit with you while you talk to patients, and tell them what you're looking for, that, as a novice nurse or new to palliative care or new to depression all on its own, watching and listening and learning is for me, a really great tool as well.
Any
So we won't
education on
brush
how to help?
depression off anymore, right, Nancy? That's the
Oh,
message.
no, absolutely not.
It's a very serious
Absolutely
disease,
not.
and so we can't ignore it. We need to dig in deep and ask the questions.
Mhm. So Carol Northcott states that I don't remember the specifics of the study I saw, but their findings indicated only 17% of patients at end of life are depressed, and would that fit with criteria? And you know, Carol, I actually did look at a study that was actually 1 to 14%, and so that does definitely fit right in there. And I have to say that it was interesting because it depends on where the study was taken and this at what stage the patient is at, and if it was a high tertiary, like a cancer care center, right? That
Tertiary
actually,
center.
thank you, my pronunciation, where your population is going to be higher than in family practice. Right. So there were so many factors that rolled into coming up with the findings from the studies. So yes, it would fit criteria for sure. Even though it looks like it's a low percentage, the fact is they still can be helped. Right.
And
Thank
just
you, everyone.
remember,
There was one, sorry, there was one more question here.
okay.
Have any ideas or education on how to help the family deal with the depression of a loved one?
Oh boy. The first thing in the first place that I think of actually is hospice care. If this is a patient that is at the end of life and they have been connected with hospice care, because they also deal with family. Otherwise, I would certainly speak to your primary care provider. Some people are really comfortable. Some primary care providers are very comfortable having conversations with their patients and their families. And that's where I would send you. I would say primary care, your physician, and then if not, maybe some hospice outreach work would be of benefit.
Remember the enormous responsibility and stress of that caregiver. You know, and so to then add depression on top of already very complex disease, I would be interested to do a study and see how many caregivers develop depression while taking care of very profoundly unwell healthcare or their loved ones. Sorry. And just to remind ourselves that we speak a different language in healthcare, and remembering that often we have to be careful how we word things so that we're not using our medical jargon, that we're talking on a level that patients and families can understand, and really importantly, normalizing this disease just like any other disease, so that we can sort of start to dispel all those myths and the bias and the judgment that comes along with someone needing psychological support. We really do need to start to embrace that this is a disease, just like type 2 diabetes. And we would never, ever stop somebody from going to physiotherapy after they broke their hip. No one would think anything of it, but there's a different thought process when it comes to mental health. And we've got to get that message out that that it isn't something that people can control all on their own.
That's an excellent reminder, Sherry. Thank you so much. And thank you both so very much for your time, and to everyone who joined us here today. We look forward to seeing you all at our next session, and be sure to remember to fill out that satisfaction survey and keep an eye on your email for some follow-up links that will be sent your way. Have a great day, everyone.
Thank you so much. Have a great day.
Thank you.
Thank you, Nancy. Thank you, Amanda.